Next up, we'll be talking about aspects related to endocrinology, and I'll begin by talking about disorders of the anterior pituitary, where there is a pituitary adenoma which is causing excess production of growth hormone. Well, for acromegaly, which will occur after puberty, there will be no increase in the height of the person. Rather, what will increase will be the size of the hands and the size of the feet of the patient, and therefore he might use this phrase spade-like hands to describe the increase in the size of the hands and increase in the thickness of the fingers of the patient. So if he's having, let me say, a wedding ring in the hand, then he might have to get this ring cut because it might get stuck because of the increase in the soft tissue mass in the hands of this person. When it comes to the anterior pituitary, the cells that produce the growth hormone, that is somatotrophs, are the overall most abundant cell of the anterior pituitary. I repeat once again, from physiology domain, the most abundant cell of the anterior pituitary happens to be a somatotroph. It would be a somatotroph based tumor which will cause not an increase in height but increase in the size of the hands or the feet of the patient. There would also be increase in the size of the mandible, and the growth of the mandible would be referred to as prognathism. Similarly, he might have to change his shoes because of the dramatic increase in the foot size of this patient. And you cannot standardize foot size. I mean, the foot size for a Asian versus a American versus a African will be different. So a parameter that we use to monitor growth and specially monitor about the growth of the tissues that occurs in acromegaly is heel pad thickness. It's a radiological parameter. You would be doing an X-ray of the foot of this patient, and this X-ray of the foot is mainly to check for heel pad thickness, which keeps on increasing in these patients as the disorder progresses. So why I'm describing it is because let us say a person is having a pituitary adenoma before puberty. Like somebody is having a pituitary adenoma contributing to gigantism. Then to evaluate gigantism, all you need to do is check out the height of the patient and compare it with the growth charts available. The child will be the tallest of all the children that have been ever recorded in history, because there would be a tremendous scope for growth of the physical height. But in acromegaly, nothing like this is possible. So that's why you call it acromegaly, because there's going to be a peripheral part enlargement in the patient, and the increasing size of the pituitary adenoma can also cause visual deficit, which you can see in blue. That would be a bitemporal hemianopia. Most of the time, the question that is given on the topic of acromegaly is self-explanatory. The clinical details which is put in the first star mark are so simple and straightforward that nobody will miss up a clinical diagnosis of acromegaly. It is just the fact that he will rather talk about a screening test or about the investigation of choice. And the main game in endocrinology topic is that if you know screening test, investigation of choice, you are half done with the MCQs of the topic. Now, before I talk about the screening test for this condition, I'm giving you a few seconds to think about it. And I just want to tell you that sometimes there is a possibility that even the lactotrophs, I told you that the main cell which is the troublemaker here is going to be somatotroph, which will be producing excess amount of growth hormone. But even lactotrophs might be involved in this condition. So sometimes you might be having a tumor which is a combination, or rather is producing excess of a combination of growth hormone and prolactin. Because prolactin can be increased, don't be surprised if we will also talk about galactorrhea in this patient, which is the reason why you might be thinking to yourself that is he talking about prolactinoma? But if he's going to talk about a prolactinoma, either in a male or a female, he will talk about infertility. Whereas in this particular question, instead of talking about infertility, he will rather focus on the increase in the hand size or the foot size, or maybe the hat HAT, like in America, like in Texas state, they wear that big hat. So increase in the hat size of the patient. Galactorrhea was mentioned in one of the FMG exam MCQs, so that's why I thought I should just say it, because lots of guys, when they read about the galactorrhea component, they said, sir, in first two lines of the MCQ, I thought it is acromegaly, then galactorrhea was the one which was causing me to doubt my diagnosis. In a PG entrance exam, they did not ask for diagnosis, they said what is the screening test. I think I gave you sufficient time to think about it. You would be checking out for the values of IGF-1, that is insulin-like growth factor 1, that is a somatomedin, and the levels of this would be skyrocketing in this patient. Then comes the investigation of choice. Do not answer growth hormone levels here, because growth hormone levels are never constant. Growth hormone is always produced in a pulsatile fashion. So we are not able to determine, there's no standard fixed rate value below which or more than which we can say, okay, this is excess and this is lesser. So rather what we do in this patient is glucose challenge test. Traditionally, we read about glucose challenge test with respect to diabetes mellitus, but here I am today teaching you that I will be giving a 100 gram glucose to this patient. And normally when you give glucose to somebody, it can cause suppression of the values of growth hormone. But a pituitary adenoma is not supposed to respond to physiology just like your and my pituitary will do. So in this patient, the glucose challenge test will fail to suppress. You see, in endocrinology, either the investigational choice is a stimulation test or is a suppression test. So I said in a normal person, the glucose, if administered, causes suppression of the growth hormone levels. But in these patients, when you do a glucose challenge test, you will notice that in spite of giving the load of glucose to the patient, the growth hormone levels of this patient will persistently remain more than 1 nanogram per ml. Now, we do have tests available where we can pick up as little as 0.04 nanogram of growth hormone. But traditionally speaking, this is what most books say, that the literature given in the MCQ will be failure to suppress growth hormone levels beyond a certain point. And this value 1 that I said is given in most books, though it can vary. So the main concept is glucose challenge test is useful in diabetes and especially gestational diabetes, but even for diagnosis of acromegaly. And I'll obviously supplement that with imaging. We'll be doing an MRI head in this patient, and that will pick up a pituitary tumor. Now for the treatment of this patient, which is again a MCQ, you will have to first shrink the size of the pituitary, because when you shrink the size of the pituitary, then all these visual deficits would also become relatively lesser. There would be a symptomatic improvement in the patient. So we will be giving a long-acting octreotide derivative. So we read about octreotide infusion for bleeding esophageal varices, but we will also be reading regarding octreotide derivative lanreotide depot formulations being given to these patients who are suffering from acromegaly, and subsequently we can plan a transsphenoidal surgery for these patients. Especially if there's a visual deficit, then subsequently surgery would be done. Now I'm not writing transsphenoidal surgery because that's very easy for anybody to remember. For any pituitary adenoma producing mass effect, we will have to reduce the pressure on the optic chiasm and transsphenoidal surgery would be done. But when the surgery would be done, the surgeon might be a little conservative in a sense that he might leave behind some somatotroph adenoma cells, and once these cells are left behind, they'll multiply again and you could have recurrence of manifestations. In case you have recurrence of manifestations, then patient is not going to agree to surgery once again. He already underwent a transsphenoidal surgery in your hospital, let me say 2 years back. Now there's a recurrence of the manifestations that once again, all things that I said, like increase in the size of the hands or thickness of the fingers is increasing. So in those circumstances, you would like to give a drug that will not reduce the growth hormone production, but will basically act on the growth hormone receptors and block them. Once you block the growth hormone receptors, growth hormone will not be able to act. So if he says recurrence of tumor, recurrence of a somatotroph based tumor, and this tumor is causing manifestation symptoms in a patient, what is the drug recommended? You will change your answer to peglisomab. But if it is the initial presentation of the patient, the preferred drug would be given as an octreotide derivative that I mentioned. Octreotide is useful for secretory diarrhea. It is useful for bleeding esophageal varices. And currently the long-acting variant is what I have described with respect to acromegaly. Now, when it comes to endocrinology, most of the time I can say that if you can answer the investigational choice, half your job is done. At least 50% of the job is done. So let's talk about the investigations that would be done for diabetes insipidus versus SIADH. Lots of time you're gonna read SIADH as a paraneoplastic manifestation with lung cancer. For diabetes insipidus, it could be central or nephrogenic variety. For diabetes insipidus, the test that you're gonna do would be a water-based test, and I think the first one is the easiest in the lot. All of you can pick this up, water deprivation test. But when it comes to SIADS, the test we'll be doing, it will be opposite. You just need to use English in this case. That would be a water loading test in the patient. Then we'll also talk about depletion of aldosterone, cortisol, sex steroids versus increase in the values of aldosterone. That would be Conn syndrome. One of the reasons for Conn syndrome that you need to remember is adrenal adenoma. Do not answer bilateral adrenal hyperplasia, answer it as adrenal adenoma. Though I'll talk about cons and additions subsequently as well, but at the moment I just want to say that bilateral adrenal hyperplasia is one of the important causes for primary hyperaldosteronism. But if he uses the word con syndrome, he is not talking about bilateral adrenal hyperplasia, only one side adrenal gland is involved and there's a tumor present there. Now the test we will use in this particular case would be a saline infusion test. Lots of time you might even read the word salt loading test. Now it will look very tempting to answer salt loading test, but remember in con syndrome already aldosterone is more, already there is more salt in the body, already there is high BP, and if you load the patient with large amount of salt loading, you see, you will argue sir saline is also having salt, agreed, but the amount of salt is lesser, no? So salt loading test can be done, but it is found to be relatively more risky and runs the risk of hypernatremia. So in the textbook he first mentions saline infusion test. In contrast, in Addison disease, the adrenal gland of the patient is damaged either by autoimmunity or maybe by infection like tuberculosis. If the gland is destroyed, I would like to try and stimulate it. So the test we will do here will be called as ACTH stimulation test. MCQ wise, instead of saying the word ACTH stimulation, he might even write the word co-centropin test. So either of the two, if written in a MCQ, ACTH stimulation or co-centropin test, they both mean the same. What we are doing here is trying to stimulate the adrenal gland, which will fail to respond to the challenge because tuberculosis has destroyed it. When we are going to go in for evaluation of pheochromocytoma, where they will always talk about this PhD mnemonic, that would be palpitations, headache and diaphoresis. The headache is explained by the hypertension in the patient. So in pheochromocytoma, you will read about two tests. One will be a urine test. That is going to be a 24-hour urinary fractionated metanephrine levels. However, if he says what is the this table is about investigation of choice. So I will talk about pheochromocytoma subsequently also. But just because this is rapid revision, the test that we do for pheochromocytoma is a plasma-free metanephrine levels. Now at this point of time, I'll just caution you to the fact that in the urine, the test which was the screening test, the urine test was a screening test. The term I used was fractionated metanephrine. And when I'm talking about pheochromocytoma investigation choice, I'm saying plasma-free metanephrine levels. Though you will argue, sir, after all, it's going to be metanephrine. That's okay, but that's the perfect terminology that is used. And at this juncture, what I'm saying next is actually not supported by Harrison. But for your FMG exam, you will notice that at least in 2021 and 2022, both times when they have talked about pheochromocytoma, there was no mention of metanephrine in the options. They picked up the question for diagnosis of pheochromocytoma from Robbins. The Robbins, the textbook of pathology, will rather talk about 24-hour urinary VMA, that is veneal mandelic acid. So though this will be given in the notes of yours and you're gonna ping me, if you're gonna read only notes, you're gonna ping me saying, sir, what should we answer actually in the exam? So the answer in the exam is what is written in black uniformly, that is plasma-free metanephrine level. Suppose this is not given, then the answer should be given as 24-hour urinary VMA levels, that is veneal mandelic acid levels. Then comes the issue of carcinoid syndrome. When it comes to carcinoid syndrome, we'll be evaluating the urine of this patient, but this time the urine will be evaluated for 5-HIAA, that is hydroxyindole acetic acid, and this is going to be end product of metabolism of serotonin. Just like you have in pheochromocytoma, excess of norepinephrine and epinephrine, similarly in carcinoid, it's going to be serotonin breakdown that would be occurring, which will cause HIAA levels to spike. For acromegaly, I've already told you, it would be a glucose challenge test, and I will be trying to suppress the production of growth hormone, but the pituitary has other mood, so pituitary will not follow what the physiology will be saying. For identification of a prolactinoma, we need to run a serum prolactin level, and along with this, imaging would also be required so that I can demonstrate a pituitary adenoma. Same would be the case with acromegaly as well. For Cushing syndrome, very interesting, you will read terms like overnight dexamethasone suppression, low dose dexamethasone suppression, and then high dose dexamethasone suppression. Now for the differences between the three, you need to go up to the main videos. In rapid revision, I want you to remember that the IOC should be answered as low dose dexamethasone suppression test. And I know that you're going to ping me directly saying, sir, why not a high dose dexamethasone? Well, ideally, I can ask you to go back to the main video, but still, At this point of time, I want to tell you that for high dose dexamethasone suppression test, it looks like very good test, no high dose. But the point is, high dose dexamethasone is useful for differentiating between whether pituitary is the cause or whether lung cancer is the cause. Like if I want to differentiate between two, see, there are two things. First, you diagnose the disease, then you diagnose the cause of it. So to diagnose the disease, you do a low dose dexamethasone suppression test. And then for etiological diagnosis, like to differentiate whether it is a pituitary adenoma, that is Cushing disease, versus whether it's going to be a case of lung cancer contributing to it, because lung cancer can also be, wood cell cancer can also be contributing to development of Cushing syndrome. So to differentiate between whether lung cancer is causing it or a pituitary adenoma is going to cause it, I will be doing a high dose dexamethasone suppression. And I think you would agree that you can't suppress lung cancer by high dose and super high dose. I mean, whatever dose of Dexona you give, can you suppress a lung cancer which is producing excess amount of cortisol? You can't, but you can still suppress the pituitary. No, pituitary will at least give some respect that okay, doctor is giving extra amount of cortisol, so I should shut down my production of ACTH. So the point is that ACTH will be produced in excess by a pituitary adenoma also and by lung cancer also. The lung cancer, ultimately, the excess ATH will act on the adrenal gland and produce excess of cortisol. Cortisol is elevated in all the causes of Cushing syndrome. ACTH may or may not be. You see, the most common cause of Cushing syndrome is exogenous steroids. If somebody will take steroids from outside, ACTH will become less. So Cushing per se is not a disease of ACTH values. ACTH values can be less if the guy is taking gym supplements, that is, let me say steroids. On the other hand, if it's a pituitary tumor, ACTH levels will be elevated. So ACTH value can be less or more. This is a disease of extra cortisol in the body. Cortisol values in the body have a diurnal variation. In Cushing syndrome, we have loss of diurnal variation of cortisol production. So to demonstrate that loss of diurnal variation, I need to check out the cortisol values, but I need to check them after doing a suppression test. So low dose dexamethasone suppression is the best test for identification. For etiological diagnosis, lung cancer as a cause versus whether it's going to be a pituitary adenoma, I will do a high dose dexona subsequently. Then he has asked about pituitary adenoma imaging. There are 4 parathyroid glands and the tumor could be originating in anyone, but it is usually an inferior parathyroid gland where a parathyroid adenoma will arise. And the imaging that I will be using, I will be checking PTH values. I mean, if I just ask you, how do I identify a pituitary adenoma is present in the patient or not, check out PTH value. See, I will not answer imaging then. If I want to demonstrate there is a tumor in the body, I need to do a test which will tell what is the tumor producing. So a parathyroid adenoma will be causing excess amount of PTH, so I'll check out serum PTH values. But that's pretty straightforward. The question said imaging. I mean, you need to say, okay, this is inferior parathyroid gland which is causing excess production of PTH. So the test that I'll be doing here is called as system EB scan. And the point is that system EB scan has been discussed even in cardiovascular system, that is technetium 99 scan in myocardial perfusion imaging. System EB scan is discussed in cardiovascular system with respect to myocardial perfusion, and has been discussed today even for identify a parathyroid adenoma, and mostly it will be a inferior parathyroid adenoma. This slide that I made before you, if it is making sense, it means that you have fair background amount of knowledge with respect to endocrinology. Once we get these tests right, next on the agenda would be to talk about the posterior pituitary, and 2 diseases that would come up here would be diabetes insipidus versus SIADH. Well, for SIADH, most of the time it's going to be lung cancer as a cause. And what's going to happen in this patient of SIADH is simply that the V2 receptor, which is present in the collecting duct, would be having excess hormone, which will be causing more reabsorption of water. If more water will come back in the body, the plasma will become relatively dilute. And at the same time, if all the water will come back in the body, then the urine will become concentrated. So what I want to bring to your attention is that urine osmolarity and plasma osmolarity arrows will always go in opposite direction whenever antidiuretic hormone is being talked about. I will demonstrate this once again. Suppose antidiuretic hormone is not able to act on the V2 receptor. Suppose person is having nephrogenic diabetes insipidus. If nephrogenic diabetes insipidus is there, then this water reabsorption will not occur. All the water will flow out of the body. That is, the urine of the person will be extremely dilute. So you can see the arrow would be going down. Now, if you lose water from the body, then the plasma will become relatively concentrated, and therefore the plasma osmolality will be increased. The game in the MCQ is all about arrows. He will say all are correct about diabetes insipidus versus SIADH. So you need to get these arrows correct here. I'll repeat the logic once again. In diabetes insipidus, the correct word was loss of water from the body. Whereas in SIADH, as the name is suggested, there is going to be gain of water in the body, and the gain will contribute to a hyponatremia component as well. So if I just move a little forward, when I talk about sodium concentration, it means sodium divided in the body by the salt in the body divided by water in the body, and water is more. So because the water is more, therefore sodium concentration will become relatively lesser. The technical term I can use is dilutional hyponatremia. On the other hand, if I lose water from the body, loss of water from the body will cause a relative hypernatremia. Now, if you look at the arrows here, you will notice that if you can work out urine osmolality value, plasma osmolality arrows will always be going opposite. If you look at the concept here that I've given you is, if you can work out the urine osmolality value, just invert the arrows for the plasma osmolality and the sodium concentration. Obviously, you will use logic in the exam, but what I'm trying to give you is a quick hack. I mean, if your arrows in the exam are going in same direction for urine as well as plasma osmolality, if these two arrows are going in same direction, it means your thought process is wrong with respect to antidiuretic hormone. Now listen to my next words even with more care. If a patient is having psychogenic polydipsia, he will keep on drinking water all day long. If a person will drink water all day long, then it would result in development of dilution. So all these arrows will go in same direction. If you encounter a question in which urine osmolality, plasma osmolality values are given and arrows are going in same direction, it means that this is not a question related to endocrinology topic. Just to sensitize you to this, let me give you a situation. A person is having damage to his thirst center. You very well know thirst center is present in our hypothalamus. The technical term for the thirst center is OVLT, that is organum vasculosum lamina terminalis. OVLT is organum vasculosum lamina terminalis. This is the technical term for the thirst center, which makes us drink water intermittently. Whenever we are, continuously speaking, we get tired, we drink water. But imagine somebody's OVLT has been damaged because of head injury. Therefore, person will not feel thirsty at all. This particular person who's not feeling thirsty at all could be suffering from this disease, which is called as adipsic hypernatremia. When I say adipsic hypernatremia, the concept is the person will not drink water. Forget about a few hours, even for a day, maybe he can go without water for 2 days, maybe 3 days. Lips are parched, tongue is dry, and he is going without water. If somebody is not going to drink water, that you to the level that you have to forcibly make him drink water, then everything in the body will become concentrated. So in case you get questions where the arrows of urine and plasma osmolality are going in same direction, that means that the questions are not related to antidiuretic hormone. On the other hand, you will notice a lot of questions that came in AIPG format or in NEET PG. They were mainly having this concept going with respect to the urine and the plasma osmolality is going in opposite direction. As far as the sodium component is concerned for hyponatremia, the hyponatremia in this particular case, though I said the word dilutional hyponatremia, the technical term that you need to remember for SIADH is not hypovolemic hyponatremia, neither hypervolemic. This condition is having more water in the body. So logic of most people is that more water in the body should be causing hypervolemic hyponatremia. But the problem in this patient is, listen to the words very carefully. There are two things. One is total body salt. Second is total body water. What is happening in this patient is that total body salt is normal. It is total body water that is more. Because the water, thanks to antidiuretic hormone, which is in excess. If you want to say the word hypervolemic hyponatremia, hypervolemia will also cause dilution, but hypervolemic is when total body salt is also more. Here you can see total body salt is normal because antidiuretic hormone has nothing to do with salt. It only causes more water, no? So if you are having more water in the body but salt is normal, you don't call it hypervolemic. You call it euvolemic, and the dilutional component will explain why I have written hyponatremia. On the other hand, suppose in a case, and I'll explain this in the kidney section also subsequently, if total body salt is also more and total body salt amount is increased, and let me just put arrows here to say that in this particular case, the water I have put, let me say 3 arrows, and in front of salt I have put a single arrow. So again the dilutional part is coming up, but here because both of them are elevated, the salt component is also more and the water component is also more. So the technical term that you will use for this one will be hypervolemic hyponatremia. I will be discussing this euvolemic and hypervolemic hyponatremia subsequently in electrolytes component, which would be discussed with respect to the kidney part. But at this point of time, I just wanted you to be sensitized to the fact that whenever it's gonna be a hypervolemic hyponatremia, then the villain responsible for this would be aldosterone. Now this will become more clear in the kidney section, but at the moment, two messages for you guys. Whenever antidiuretic hormone is more, it does not cause a hypervolemic hyponatremia, it causes a euvolemic hyponatremia. Definition of euvolemic is total body salt is normal, it is total body water that is more. But if it is water and salt both more, you see, forget about arrows, but the point is both are more, that is when you use the term hypervolemic hyponatremia in a patient. And this also explains that in hypervolemic hyponatremia, you need to neutralize aldosterone. So you might have to give spironolactone to the patient. But in euvolemic hyponatremia, which is caused by SIADH, because SIADH was causing more activity of the V2 receptor thanks to the excess amount of hormone, I can block this activity with the use of Vaptans, which explains the fact that why in a MCQ, he will not say Vaptans are useful for SIADH, that he knows you will crack. He will say Vaptans are useful for treatment of, and you will answer euvolemic hyponatremia, which is a very characteristic feature that you encounter with patients of SIADH. On the other hand, if he says what drug would you useful for hypervolemic hyponatremia, like in heart failure, person is having hypervolemic hyponatremia thanks to excess of aldosterone, I would like to neutralize this aldosterone by using maybe spironolactone or eplerenone, and I can also give diuretics to the patient. The diuretics will cause loss of water from the body, that will reduce the edema component in the patient as well. So I'll not go into the treatment of ascites and heart failure at the moment, but ascites and heart failure are two conditions where aldosterone is more and you need to neutralize it by giving diuretics to the patient and even using spironolactone if warranted. Like in ascites, we use spironolactone. But for patient having a euvolemic hyponatremia, it is Vaptans which are to be used. Two main messages from this particular slide would be: one, the direction of arrows of these has to be worked up. This is not 4 different MCQs. This is in a single MCQ. He's going to say all are correct about these conditions except, and you need to remember this increase decrease, because in endocrinology, either it's about investigation of choice or it's going to be about the increase or decrease due to the feedback effects which are occurring in the body. When it comes to euvolemic and hypervolemic hyponatremia, this will be discussed subsequently in the kidney section also. So you can listen from there also, because there I will talk about hypovolemic hyponatremia also. So if I get into hyponatremia at the moment, then the endocrine component would be neglected. And anyway, for central diabetes insipidus, we use desmopressin. I'm not writing it because you know that from pharmacology. For nephrogenic, we shall be using thiazide group of diuretics. And the query I can put up before you guys is, as I do in the main video, thiazide is a diuretic and diabetes insipidus is having polyuria. So if it's an educated patient, he will ask you, sir, I am already passing 6 liters of urine every day. You are giving me a diuretic. You are going to kill me. You have an intelligent patient who says, sir, I'm already having large amount of urine production. You are giving me a diuretic. The point is that thiazides are useful for nephrogenic diabetes insipidus, because when you give this thiazide diuretics, they actually act on the osmoreceptor. They act on OVLT and reduce the drive for drinking. And because the drive for drinking will be lesser, if he will drink less water, urine output will also become less. So when you give thiazide diuretic, common sense says it will cause diuresis. Agreed, it will cause diuresis. But at the same time, it will suppress the osmoreceptor in the body. And by suppressing the osmoreceptor, if the polydipsia component will become less, if the intake of water will become less, then the output will also become less. So that is the logic behind why thiazides are answer for nephrogenic diabetes insipidus. And then I can say one more fact, that's again from pharmacology/medicine. Drug causing nephrogenic diabetes insipidus is lithium. Treatment was primarily what we discussed. I mean, if you have a treatment for nephrogenic diabetes insipidus, thiazides. He said drug contributing to nephrogenic diabetes insipidus, and that would be lithium, and people casually mark thiazides, which is a common error of judgment, because as you progress, like in this video, as you're progressing towards from neuro to endo, fatigue sets in. Similarly, in the exam, in the second hour or third hour, it is mostly the fatigue factor that contributes to decrease in the ability to score, and that causes a decrease in the ranks. So whenever you're giving a mock test, try to keep longish sessions. Even when you're listening to these videos, I would like you to maintain your focus for minimum at least 3 hours, because exam is gonna be of that duration that will make your back feel tired. So that physical stamina has to be there to sit in front of the computer continuously, gaze at the screen, and your mind is racing at that point of time, right? The mind is accelerating. The acceleration in the first minute and the acceleration in the last minute should be the same. Just like Ronaldo, no? Just he has a lot of stamina. First minute of match, last minute of match. He runs with the same physical capacity. Same is what is expected out of you. You're supposed to perform like a high performance athlete in the actual competitive exam. So try to extend your sitting sessions so that you are able to perform optimally. And this would be a quick comparison with respect to the hormone from the posterior pituitary, which is produced in the hypothalamus but is released from the posterior pituitary, and I've compared the urine plasma osmolality and sodium concentration values, which will be asked in all except format for this particular topic, which is mentioned in green. Next up, we're going to talk about diabetes mellitus, which would be 4 varieties: type 1, 1.5 diabetes, which is also called as LADA, that is latent autoimmune diabetes in adults; type 2 diabetes, and then MODY, that is maturity onset diabetes in young. Overall, if they ask you which of these would be rarest out of the 4 varieties, then your answer would be given as MODY. Whereas if he says that which of these would be the commonest one that would be encountered, then it would be type 2 diabetes. In fact, India is the hotspot for diabetes mellitus, and majority of cases are those of type 2 diabetes mellitus. Now, when it comes to type 1, if you check out RIA, that is radio immunoassay insulin levels, the values would be lesser and the beta cell mass would be reduced. And usually when we have more than 80% reduction in the beta cell mass, that is when the manifestations occur in the patient. Now the question arises, why is this happening? Then one of the important causes for development of the manifestations would be autoimmunity. Apart from autoimmunity, another important cause that must be remembered by you is fulminant diabetes. Now, when I use this word fulminant, it looks a little surprising because traditionally we always read about fulminant hepatitis. But here I'm teaching you about fulminant diabetes, and the reason for this would be viruses. Most of the time the viruses which could be incriminated here could be like the Coxsackie virus or the mumps virus or the rubella virus. So they can cause mayhem and destroy the beta cell of pancreas. Now, when we compare this with type 1.5 diabetes mellitus, even in this condition, the radioimmuno insulin levels will be showing less insulin, the beta cell mass would be reduced, and the reason behind this is again autoimmunity. But in the exam, he would love to ask you regarding the name of the antibodies, which are the villains here. So for 1.5 diabetes, the antibodies that you'll answer will be: one is anti-GAD antibody, that is called as glutamic acid decarboxylase antibody. Another one which is to be remembered here is anti-ICA, that is anti-insulin cell antibody. In fact, as far as anti-ICA is concerned, it is unlikely to be asked because you can guess about it a bit, insulin cell antibody. But then anti-GAD is what you need to remember. And on comparison with type 2 diabetes, which is I would say the adult manifestation, type 1 is pediatric onset mainly. 1.5 has an adult onset, and type 2 also is an adult onset diabetes. You will notice that initially, because the receptors are not working, so the levels of insulin will be elevated. But in the later phase of the disease, there will be a beta cell exhaustion. And when this beta cell exhaustion will occur, that is when sulfonylureas will stop working. At that point of time, you will have to start the patient on insulin, and the levels of insulin in the blood would be lesser. You see, the point is, initially in type 2 diabetes, we use oral hypoglycemic drugs. But subsequently, they fail to cause a control of blood sugar. The HbA1c levels will once again start rising after years of control. That's because beta cells are not tired. They're exhausted by producing excess amount of insulin. And that is when you need to give insulin from outside. And the message is in all the forms of diabetes, ultimately, the levels of insulin will fall. Now, in type 2 diabetes, the problem is in the receptor. The beta cell mass is perfectly normal. So the question arises, why do you have type 2 diabetes mellitus? In fact, that's an important question which was asked in the exam. Agreed that receptor is defective, but why is the receptor defective? You see, till let me say 40 years of age, everything was fine. Then usually at 40, 45, 50, type 2 diabetes is identified. So the question arises, what is causing that receptor to misbehave? Earlier it was responding beautifully. When the patient was a child, the receptor was working fine. Now suddenly it is misbehaving. So your answer in this case would be given as polygenetic. It is defective genes which are responsible for 8 of them actually for development of type 2 diabetes mellitus in a patient, and they affect the levels of adipokines. They affect the levels of adiponectin. You see, adiponectin in pathology is called as guardian angel against obesity. In type 2 diabetes, this adiponectin levels will become lesser. So the person will also tend to become, if not obese, at least there would be weight gain seen. Though in Indian patients with type 2 diabetes, we usually do not get a very substantial weight gain. But in American patients, you definitely find substantial weight gain present to the level that the person can have obesity and even morbid obesity occurring. Now, when it comes to the rarest form of diabetes, that is MODY, the levels of insulin will be lesser even in this case. And when I'm describing it, the question that is coming up from most of the students would be that, sir, what is the difference between type 1 diabetes and MODY? If in both of them, it's going to be a less amount of insulin. Well, the difference is, and you can notice in the table that beta cell mass is reduced when it comes to patients of type 1 diabetes mellitus, but the levels of beta cell mass will be normal when it comes to MODY. And the question then arises, in this peculiar format, what is the reason? The answer would again be defective genes. The pattern of inheritance of this disease is autosomal dominant. And because it is autosomal dominant, it will be expressed in every generation. So you would have a patient who maybe will be diagnosed at 25 years of age. When it comes to MODY, majority of patients, the peak age of onset is about 25 years of age. And why they come to you, he says, sir, I got the shock of my life. Like this guy, he got a job in a good software company. And he says, like, when the company sent me employment letter, they also said that I have to get a basic pre-employment medical checkup done. So I went to some XYZ lab, which was designated by this company. Like he went to Lal Path lab and he gave his blood sample. And he says, doctor, I got the shock of my life. I don't have any symptoms, but my blood sugar turned out to be 300. And he thought that it is an error on the part of the laboratory. So he decided to get this blood sugar tested from a different laboratory as well. And the other laboratory chap also advised him to get a HbA1c values done. You very well know that HbA1c values would be superior as compared to a fasting blood sugar value, because fasting blood sugar value can be affected by a lot of factors. But when it comes to the testing the second time in this patient, again the blood sugar random was elevated, fasting sugar was elevated, maybe he got a glucose tolerance test done also, the 2-hour value was also substantially elevated, HbA1c was elevated. He says, sir, I don't have symptoms. I got my blood sugar tested from 2 different labs. I got specialized test. He will not say words like HbA1c. He just says, sir, I got the specialized test done from a XYZ lab and the values are were found to be elevated. And he is also informing me that my dad is also a diabetic and my grandfather is also a diabetic. He says, I thought I will also develop diabetes, but maybe in later part of my life, not at 25 years of age. So when you get a history like this, where diabetes is running in generations, at least 2 or more generations are affected. In fact, that's one of the important diagnostic criteria for MODY, that at least 2 or more consecutive generations should be affected. In type 2 diabetes mellitus, in between there might be skipping of a generation. When I say skipping, I mean like grandfather might be diabetic, father would be fine, father's elder brother and younger brother are also fine, and then this guy turns out to be diabetic, but in between there was a skipping of a generation. But in MODY, it would be more than 2 consecutive generations getting affected, and most of the time what we find is that the most common form when it comes to MODY would be MODY3. In fact, there are subtypes of MODY also, ranging from MODY 1 to 6. We call them MODY 1, 2, 3, 4, 5, 6. And usually the question that comes is on the commonest one that is encountered in either both India as well as in America, that is MODY3. For MODY3, you need to remember the chromosome involved is chromosome number 12, and the gene which is defective is HNF1 alpha gene. The important data in this particular table and has been asked both in NEET PG as well as in FMG exam is the reasons behind development of type 2 and reason behind development of MODY. As I've explained to you, and I have used different colors to explain this, for type 2, the answer would be given as polygenetic, and for MODY, your answer would be autosomal dominant. Especially they've talked about MODY 3, that would be chromosome 12, and HNF1 alpha gene being defective. Most patients of MODY, when they initially present to you, would be asymptomatic, and it is just on a maybe on a pre-employment medical checkup that would be mandated by a lot of good companies that this guy was found to be diabetic. Now, for management, especially type 1 diabetes mellitus, we will have to use insulin even in type 2 when there will be beta cell exhaustion. Initially, in type 2 diabetes mellitus, the values of insulin are elevated, but subsequently, when you get a beta cell exhaustion, then medicines, oral hypoglycemic drugs will not work, and you will have to give insulin to the patient. Now, how can you give insulin to the patient? Well, there are various ways. Most Indian patients would be purchasing a multi-dose vial, and from there they'll be using an insulin syringe. You will teach them how to give insulin, obviously, and we also have pre-filled syringes available, which would be especially useful if the patient is traveling, because you see a glass container or glass vial of insulin can break during the journey as well. Then when it comes to the ideal method, preferred method of delivery of insulin, then I can say that it would be an insulin pump which would be recommended, and the technical term that would be used for insulin pump would be CSII, that is continuous subcutaneous insulin infusion. Though the patient can also carry an insulin pen, and he just needs to purchase the cartridge of it, and on the insulin pen you can actually adjust the dose of insulin which can be given. Like at the moment you can see that there is a marking which is present, and visible markings present by which you can know that how much insulin would be given to a patient. So it would be pretty handy, though obviously it will require a bit of training on your part, and economically speaking the patient has to be able to afford a insulin pen, and this is the cartridge that I was talking about that has to be loaded once the insulin is exhausted. So to overcome this disadvantage where the insulin pen has to be always carried, you could be having a insulin pump which a patient can just hook up to his or her jeans or pants, and then the insulin would be delivered subcutaneously to the patient. The advantage of an insulin pump would be that suppose I'm saying the patient is not able to eat anything, then the patient can switch off the delivery of insulin. Like suppose there is a couple with a diabetic child and they're going on a holiday, and unfortunately when they went for the holiday, maybe for a hill station, and there was a landslide, and they are not having food supply now at this particular point of time, so they can switch off the insulin pump. Similarly, you can increase the dosage of insulin also with the help of insulin pump. And the biggest advantage is, just like when you are not eating at the moment, like suppose you are listening to me at the moment, you are not eating anything, but still your pancreas is producing some basal insulin. So the advantage of this insulin pump is that it will work like an artificial pancreas, and it would be delivering basal insulin to the patient, and at the meal time you can program it to deliver a bolus. You see, the point is, just like our pancreas will produce a bolus when we eat, and when we are not eating it would be producing basal amount of insulin provided blood sugar is more than 70. Similarly, this can be programmed. A mother can program the device, and nowadays because people are tech savvy, so most of the time, if mother is educated, and children nowadays are even more, I would say, internet and phone savvy, so they can be taught how to use an insulin pump, and this would be the preferred delivery. Now, when it comes to insulin injections, suppose a patient is using an insulin pen, then what are the preferred sites where insulin can be used? So one of the important sites that can be used and can be given preference is the abdominal wall. The anterior abdominal wall, the site that I've highlighted, would be a little away from the umbilicus, about 2 centimeters away from the umbilicus, is where you can be giving insulin injections. And obviously, I would not like to keep the same site. The message here is that if you give insulin at the same site again and again, then there's a probability that there can be a development of lipoatrophy as well. So we would like to change the site. So it would be like Monday, Tuesday, Wednesday. The quadrants can be changed in a clockwise or an anti-clockwise fashion, and the patient should be instructed not to inject at the same site to minimize the chances of development of local trauma caused by the needle and a lipoatrophy. Now, suppose we have an Indian child who is also malnourished, and there is very less subcutaneous fat available. You see, you are injecting insulin subcutaneously. If the child is having very less subcutaneous fat, especially on the anterior abdominal wall, then you can also use the anterolateral aspect of the thigh. Similarly, you can also be using the lateral part of the arms as well, or in a worst case scenario, you can use buttocks as well. You see, my point is that if they just ask you what is the preferred route of delivery, then your answer is continuous subcutaneous insulin infusion. If they ask you which is the preferred site, your answer would be a anterior abdominal wall in the patient. And once you are giving insulin, one of the big side effects that can come anytime is hypoglycemia, which can make the patient have mood swings, then subsequently sweating, palpitations. And this also explains why beta blockers are not given in diabetics, because you will then mask the symptoms of hypoglycemia. I just repeat, you know this from pharmacology itself, but I'm just repeating that statement. Beta blockers are contraindicated or not recommended in patients of diabetes mellitus. The main reason is because all the symptoms of hypoglycemia are sympathomimetic. So if you mask the symptoms, then the person will not come to know that he is having low blood sugar, and the end result could be nasty, that he can end up with a hypoglycemic seizure as well. Especially if the blood sugar goes less than 40, the person will become very drowsy, and as it goes towards 20, I'm using the word neurogleukopenia, then there could be a development of seizures in the patient as well. Then they've also asked from the pharmacological perspective that which drug would be effective in both type 1 and type 2 diabetes mellitus. Then one, I said obviously insulin can be used in both type 1 and type 2. Obviously in type 1 initially, and in type 2 diabetes mellitus it would be used subsequently when you get a beta cell exhaustion. But in the exam there was no option like insulin. Then your answer would be given as pramlintide. This molecule pramlintide mainly affects the stomach motility, so it regulates the amount of sugar entering into the small intestine, and if the sugar enters into the small intestine gradually, then the spike of blood sugar, especially postprandial spike of sugar, can be controlled. So pramlintide is effective in both type 1 and type 2. And then I'm mentioning off-label drug. I'm not writing it down. Off-label drug is acarbose. Acarbose, as you know, is an alpha glucosidase inhibitor, so it will inhibit the gastrointestinal tract absorption of sugar, but because it is off-label, I have not mentioned it. The answer for the question, which was a previous year NEET PG question, was drug effective in both type 1 and type 2. Obviously, insulin can be used as I explained to you, but then there was no insulin in the option, so the answer should be given as pramlintide. Now, when it comes to the types of insulin which are available, then insulin which will be cloudy. The insulin which is going to be cloudy in physical appearance is intermediate acting insulin. Why they made it like this is mainly because especially because of moisture, if the sticker which is present in the vial comes off, you can still pick up that it is an intermediate acting insulin. And the form that we're talking about in this case would be NPH, that is neutral protamine higdon. So NPH is intermediate acting, and it will usually start acting after a few hours. If you are to take care of a newly diagnosed case of type 1 diabetes mellitus, which one would you recommend initially? You would be recommending rapid acting insulin, which can be given 20 minutes or I would say little on the lower side, maybe 15 minutes before the meal. And suppose if you're using Lispro or you're using Aspart or Glulicin, so when you administer this shot about, let me say, 15 to 20 minutes before the meal, once the patient starts eating, the insulin would be acting, but it is gonna have a short duration. So especially if you want a good control over the entire night time in a patient, especially bedtime insulin that we prefer to use would be like glargine or detamil. And the advantage of this bedtime insulin is that it is slow and long acting. In fact, lots of time, instead of just asking about long acting insulin, the question in the exam said which of the following is a peakless insulin. So when I say peakless insulin, you can see that normally the levels of insulin will rise and then will fall and will traditionally follow that bell-shaped curve. But when it comes to glargine, it would be it would not have a particular rise and a fall like you traditionally see, and it would be acting for a longer duration. Also, they've asked which is the longest acting insulin. If I zoom in, it might actually blur the image a bit, so I am just keeping it at this particular point like this. But if they ask you which is the longest acting insulin, then glargine was acting for 24 hours, and you just need to invert the data. Answer 42 hours for degludec. I repeat once again, for glargine, your answer would be given as 24, but you can invert the data for 42 hours for degludec, which would be one of the longest acting insulins. You will also be wondering that why in this table the regular insulin fact is not given. Well, I've talked about regular insulin unfairly. Regular insulin will start acting after 30 minutes. When I describe it, the query from most of the people is, sir, I mean, if you had insulin that will work within 30 minutes, then, I mean, what was the need of developing which is gonna be taken 15 minutes before meal, 15 to 20 minutes before meal? Well, I can say that for you and me, that 15 and 30 minutes may not make too much of a difference, but put it on yourself, every time before meal, if you have to take injection, then you would like to take an injection which can be taken as close to the meal as possible. So from the convenience perspective, these rapid acting insulins were used. So what is the importance of regular insulin as of today? Well, regular insulin obviously can be given subcutaneously before a meal, but the advantage of regular insulin is that we can also give it intravenously. Obviously, it can be given subcutaneously, action after 30 minutes, peak levels after 1 to 3 hours, and the total duration might be up to 4 to 8. But it can be given intravenously for emergencies. The emergencies that I'm talking about, where we will be using regular insulin intravenously, would be like diabetic ketoacidosis. Similarly, if a patient lands up in hyperosmolar coma, where the blood sugar of the patient can go up to 600 milligram per cent and even higher. I mean, such a high amount of sugar in the brain will contribute to even a cerebral edema component. So I would like to use regular insulin in this patient. And apart from this, even if a patient is having dangerous hyperkalemia, because insulin causes potassium to go inside the cells, therefore regular insulin would be useful in the patient. When it comes to intermediate acting insulin, we can be using combinations also. Like lots of time the combinations which would be available would be that of rapid acting insulin with intermediate acting insulin. So the number of shots that you need to give on a daily basis will be relatively lesser, and the long time insulin would be reserved for bedtime usage in the patient. And the technical term, as I explained to you, was peakless insulin. Then they'll have to ask regarding Somogai effect. Let's have a look at it. What I mean by Somogai effect is, like abroad they use blood sugar values in millimoles, but what I'm trying to say at the moment is that in the patient, let me say at bedtime, the blood sugar values were normal. Let me say he's a well-controlled diabetic patient. Though he is a well-controlled diabetic patient, blood sugar has been shown slightly on the higher side at this point of time, just to highlight that he is a diabetic, but it is well-controlled diabetic. Now the problem in this chap is that at night the blood sugar values are beginning to fall. Now, there can be multiple reasons behind it. One reason can be that he did not eat proper amount of his dinner. Maybe the food item that was cooked, the person does not like that food item, so he took his regular amount of insulin, but he did not eat the food item in the amount that should have been taken proportional to the dose of insulin. He ate less amount of food. Or let me say he took more amount of insulin. I mean, the patient could be having a refraction error. Let me say it's a child who's injecting himself. The child might inject a little extra amount of insulin. So if you inject extra amount of insulin, sugar values will begin to fall. Now, because of the fall in the blood sugar of this patient, at night, usually around 3 o'clock, 4 o'clock, the person is asleep, but the body is reacting to this fall of blood sugar, as a result of which counter-regulatory hormones will be released. Because of the release of this counter-regulatory hormone, especially glucagon, what's going to happen is that the blood sugar of this patient will begin to rise. And when he wakes up at, let me say, 7 o'clock, 8 o'clock, if you check his early morning blood sugar values, what I mean by early morning at this point of time is round about 7 o'clock, then the blood sugar values would be elevated. Now, the technical term that we will use to describe this increase in the blood sugar value, which is occurring at 7 a.m. by terminology in medical literature, is not early morning. I mean, for you and me by English, we wake up at 6, we wake up at 7, get ready, go to our hospital, go for work. But in the textbook, you will notice that 7 a.m. value or 8 a.m. value is described as pre-breakfast value. And therefore, the feature that I've taught you is that patients of Somogai phenomenon, you will say, will be having a pre-breakfast hyperglycemia. And when would they be having a hypoglycemia? That is at 4 o'clock in the morning. That would be early morning. You see, doctors tend to sleep at 4 o'clock in the morning. because they study usually at night time. Most doctors have more productivity at night. But my point is, from a layman perspective, 4 a.m. might be, party time for people. I mean, what I'm trying to explain to you here is that traditionally in English, early morning is taken to be like approximately 6 o'clock, 7 o'clock when you wake up. But in the textbook, that early morning thing is about 4 a.m. And the 7 a.m. thing is referred as pre-breakfast. So both the aspects have to be remembered. Somogai phenomenon, alphabet O coming up. Somogai phenomenon has a early morning hypoglycemia and a pre-breakfast hyperglycemia. If you are gonna evaluate the blood sugar of this patient in the morning, you might think that sugar is so highly elevated, you might actually decide to give more insulin to this patient in the morning, but that would not be a logical thing to do, because he took more amount of insulin at night, or he rather took less amount of food at night. So before you intervene and decide to increase the amount of insulin, you should always check out that at night time was the proper dosage taken or not. Did the amount of food correspond to the amount of insulin taken in the patient or not? And most of the cases you will find that the problem lied at the bedtime, which was responsible for either extra insulin being delivered or less amount of carbohydrate going in. Either of the two will trigger low blood sugar, which is early morning hypoglycemia, and then counter-regulatory hormones causing a pre-breakfast hyperglycemia, and this is called as Somogai effect. This is in contrast to what is called as dawn phenomenon. Now I'll describe dawn phenomenon in the same diagram. Let me just use a different color to explain the manifestations. In dawn phenomenon, what happens is that the receptors for insulin, they show a decreased sensitivity, especially between 4 a.m. to 7 a.m. in the morning. I'm not talking about you and me, I'm talking about a diabetic. So let us look at green curve. What's gonna be happening in patients who are suffering from dawn phenomenon? In these patients, the blood sugar at the moment was constant. Then what is happening is it's beginning to rise. It's showing a rise and would again peak at about 7 a.m. So you are having a pre-breakfast hyperglycemia in both. You are having a pre-breakfast hyperglycemia in both Somogai phenomenon as well as in dawn phenomenon. The difference between the two is that in Somogai there was a early morning hypoglycemia, but when he says what happens in dawn phenomenon, then I said the receptors for insulin, that is GLUT4 receptors in the adipose tissue or on the muscles, will become less responsive. Therefore, sugar will not be able to go in the muscles. So blood sugar will start rising at even 4 a.m. whereas actually it was falling in Somogai phenomenon, and that's when counter-regulatory hormones took up. In dawn phenomenon, it was no role of any counter-regulatory hormones. It was primarily the down regulation. It is like a downtime of, like, you have a server downtime, you have a app downtime. I'm talking about a downtime of GLUT4 receptors of insulin, usually between 4 a.m. to 7 a.m. in patients of type 2 diabetes mellitus. So in dawn phenomenon, you would be having is a early morning hyperglycemia and even a pre-breakfast hyperglycemia. So because pre-breakfast hyperglycemia will be encountered in both of them. Pre-breakfast hyperglycemia will be encountered in both of them. So mainly he will ask you about dawn phenomenon effect, and dawn phenomenon, as I explained, would be a early morning hyperglycemia. Now, why I'm not writing it down? Because I want you in the exam to remember one of them, and the best hack to solve this is Somogai phenomenon with alphabet O coming up. That would be a early morning hypoglycemia. So don't straight away, if somebody is having at 7 a.m. in the morning elevated blood sugar, don't try to increase the dose of insulin right away. At least see what was the problem occurring in the patient, and lots of time it will turn out to be a Somogai effect, which meant that either extra amount of insulin was delivered to the patient or lesser amount of carbohydrates were delivered. Now, when it comes to the important complication of diabetic ketoacidosis, they can also be death in the patient, because this is more common in type 1 diabetes mellitus. You always notice diabetic ketoacidosis can occur in both type 1 and type 2. It is just the fact that it is more common in pediatric onset. Why? Because there's a high probability that a child might miss the dose of insulin, either because the parents were busy or the child was sick, and therefore because he was not eating anything, the mother did not give insulin. If you have a insulinopenia, then insulinopenia will cause burning of fats in the body, and burning of fats will cause generation of free fatty acids and will also cause more production of ketones. The three important ketones that you should remember are beta hydroxybutyrate, acetoacetate and acetone, and out of the three ketone bodies, the most acidic ketone body is beta hydroxybutyrate. This should ideally be answered as the investigational choice. If the question says what is the best way to confirm diabetic ketoacidosis, your answer would be to check out the levels of plasma beta hydroxybutyrate values. If they're elevated grossly, that means it is diabetic ketoacidosis, and if it is normal and still there is a acidosis in a diabetic, then it could be lactic acidosis also. I said two concepts. I said because this is highly acidic and we'll be doing a plasma beta hydroxybutyrate values, so this happens to be the investigational choice. However, if a diabetic patient is having acidosis but beta hydroxybutyrate values are normal, then either there is a laboratory error. Now you cross-checked with your laboratory and they said no sir, I mean we did a double check and our systems are working just fine, and still a diabetic is landing up in acidosis, then it would be lactic acidosis occurring. One of the ketones that would be excreted in the breath is acetone, which will give a fruity odor to the breath of the patient. So the usual scenario that will be given to you will be of some kind of an intercurrent illness, like the child might be having a pneumonia, or let me say UTI, or adult patient having MI or COVID-19. And because there is intercurrent illness, this illness will cause an increase in the energy requirement in the body, because any illness like pneumonia, you have more energy requirements. Now, how will this energy requirement be met? In you and me, it is not sugar which will meet the energy requirements. It can go in the muscles and provide energy. But in diabetic patient, if insulin is less, sugar can't go in the muscles. If sugar cannot go in the muscles, where will the energy come from? Burning of fats, and fat burning will produce free fatty acids, ketones, and as the energy requirements increase due to increasing severity of pneumonia or any of the triggers that I mentioned here before you, more and more ketones will be produced, and therefore there will be a fall in the pH of the patient, and that means that there would be a metabolic acidosis ensuing. This metabolic acidosis will be compensated also. The compensation of metabolic acidosis is respiratory alkalosis, and for respiratory alkalosis the patient will hyperventilate, and because of this hyperventilation fight, you will use a technical term that is Kussmaul breathing. Very simple, very straightforward. Kussmaul breathing is a method of compensation. The patient is trying to remove carbon dioxide from the body, and the objective of removing this carbon dioxide from the body is to neutralize the excess protons which are being produced. Now I'm saying chemistry here. Protons, if they're extra, they'll combine with bicarbonate, which will form H2CO3. H2CO3 will break down to produce water and carbon dioxide, and as you have a higher value, as you have is an increase in the value of acidosis in the patient, there will be more carbon dioxide produced that will stimulate the respiratory center and he will breathe faster. So you get a Kussmaul breathing. Then you obviously know Kussmaul sign is what we read in cardiology with constrictive pericarditis and restrictive cardiomyopathy, and even right-sided congestive heart failure. I've talked about CRR mnemonic in cardiology, so I don't need to explain that. But diabetic ketoacidosis can cause problems, and one of the important reasons why these patients can die is cerebral edema. This was again a FMG exam question. What is the cause of death in a child with diabetic ketoacidosis? It's gonna be answered as cerebral edema, and this will correlate with the severity of metabolic acidosis and will also correlate with the values of beta hydroxybutyrate. So the question in the exam said what is the best test for severity of diabetic ketoacidosis? Though I think the answer is very obvious, I'll just use this opportunity to mention that if the question simply says what is the best test to evaluate the severity of diabetes mellitus, then I will go in for HbA1c. Higher is the value of HbA1c, more will be the complications. Like you have three patients, one having HbA1c 7%, 8%, 9%. Then person with 9% will be having higher chances of diabetic neuropathy, retinopathy. All complications of diabetes, especially the microvascular ones, correlate with HbA1c levels. So severity of diabetes mellitus can be identified with HbA1c levels, but he said severity of diabetic ketoacidosis. Now this would be best with beta hydroxybutyrate values. Higher the values, more severe. But beta hydroxybutyrate was not present in the options. Even plasma ketones was not given. So it was given urinary ketones, and urinary ketones is not a very, I would say, accurate test. So the answer here will not be 1, and blood sugar values will not talk about acidosis anyway. Agreed that if blood sugar is elevated, it means he's a diabetic, but that does not tell you that he's having acidosis component. Acidosis will be either by pH or with bicarbonate values. The correct answer to this particular question, pretty straightforward from a recent FMG exam, that is 2022 itself, would be to check out bicarbonate values by doing ABG in the patient. The values of bicarbonate will be normally between 20 to 26 milligrams, and every time you see a ABG report of a patient with diabetic ketoacidosis, the values would be usually in the range of about 15, 17, 18. Those are the usual values that would be given to you. And in metabolic acidosis, pH and PCO2 and bicarbonate, all three are reduced. pH is understandably reduced because there is a reduction in the bicarbonate, and the reason why bicarbonate is lesser is because it is going to be consumed by the excess amount of protons. You see, protons will consume the bicarbonate, and this will cause metabolic acidosis, which will cause the person to hyperventilate. The compensation of metabolic acidosis is respiratory alkalosis, so the person will breathe faster. That will cause a washout of carbon dioxide, and the washout of carbon dioxide will cause a PCO2 to become lesser. So when you attempt ABG MCQs of metabolic acidosis, you will notice the fact that the direction of arrows of all three of them will be same. In metabolic alkalosis, all arrows go up. I mean, all three values are elevated. In metabolic acidosis, all three go down. And the reason was fairly logical. I'll say once again, protons being generated, bicarbonate being consumed, and metabolic acidosis stimulates the respiratory center. So it's going to breathe faster. To small breathing, that will bring down the carbon dioxide values in the patient. So all arrows would be going in a downward direction, and this means that compensation is working. Then we have another nasty complication coming up, that would be hyperosmolar coma. Now, most of the time when you are gonna encounter hyperosmolar coma, it's gonna be an indolent course. What I mean by indolent here is that the person maybe was not identified. He till now, I mean, here I've written type 2 diabetes because hyperosmolar coma is more common in type 2. But there's a possibility that this person was not diagnosed as type 2 diabetes mellitus till he landed up in coma. Now what's happening here is that because type 2 diabetes was not being treated, the sugar values kept rising. And the blood sugar values, when they rise usually in excess of more than 600, that's when there would be problems in the patient. So you would have an unconscious, unresponsive diabetic patient, or a unconscious, unresponsive patient brought to the casualty. And in any unconscious patient, you always go in for a blood sugar value by, let me say, a dipstick, or you could urine, I mean, a urine dipstick you'll do subsequently. But initially, in any unconscious, unresponsive patient, you would still be using a glucometer to check up the capillary blood glucose. So even if he is not diagnosed as a diabetic initially, in any unconscious, unresponsive patient, capillary blood glucose should be checked. And when you looked at the values, you thought that your machine is malfunctioning because outrageously high values were coming. So you took out a blood sample of this patient, maybe only you took out a venous sample, and you decided to check out not only the random blood sugar, but even the venous blood gas analysis. You see, lots of time you may not be doing a ABG. You might be doing even a VBG. ABG and VBG, they both, either of the two can be done. Obviously, if there is problems with oxygenation, then we have to do ABG in the patient. But otherwise, when it comes to a diabetic patient, we can, the word is we can do a VBG lots of time, because ABG would be painful. Lots of time relatives may not give you permission for that, and you anyway need to perform a Allen's test, which would be time consuming in the casualty. You may not have sufficient time because you might be the only doctor on duty at that point of time. So you can take a sample and label it as VBG as well. And when the report came, what I found was pH was normal. When I found pH was normal and bicarbonate was normal, I was thinking to myself, man, everything is coming normal. Even urine dipstick is turning out to be negative for ketones. What's really going on? But when I looked at the blood sugar values of this patient, they were skyrocketing. So if we encounter a question where everything is given normal, and still it is unconscious, unresponsive diabetic, or maybe somebody whose capillary blood glucose value by finger prick method in the casualty was found to be elevated, then the random blood sugar on a proper sample is showing grossly elevated values, which can cause neuronal damage. And therefore in these patients we will have to use normal saline. In fact, the fluid of choice that would be used for both patients of diabetic ketoacidosis and hyperosmolar coma would be normal saline. At this point of time, I would also like to speak regarding insulin drip per se. Insulin drip is given in both patients of diabetic ketoacidosis as well as in hyperosmolar coma, though the dosage required is lesser. You will also read about insulin bolus when it comes to diabetic ketoacidosis, but there is no requirement of insulin bolus as far as CMDT is concerned. With diabetic ketoacidosis, if you are having a patient, and this was again a question which was a FMG based question where he mentioned that the patient is having vomiting, and he also mentioned signs suggestive of dehydration. He also mentioned patient's BP was on the lower side, and he said this question that I'm talking about at the moment was asked in the recently conducted June FMG 2022 exam, where there was a patient who was diabetic, he was dehydrated and BP was low. And he said, what is the first line intervention for the patient? And anybody with low BP with evidence of dehydration, you anyway need to give normal saline to the patient, and then you will start the patient on insulin drip. But before you start the patient on insulin drip, you should always watch out for the potassium values. If potassium in the patient is lesser than 3.5, then hold insulin drip. First give potassium correction. You can add KCl to normal saline. You can add KCl to normal saline. Watch for potassium less than 3.5. And let me say, if the potassium values are normal, that is when you would be comfortable starting the patient on insulin drip. As I told you, the dose of insulin required in insulin drip will be lesser when it comes to a hyperosmolar coma, and they don't ask dosages in the exam. So the learning for you guys is that in diabetic ketoacidosis, the treatment of choice is obviously a insulin drip. But there are two aspects which I've taught with respect to before you answer insulin drip in the question. If potassium values are lesser, then don't give insulin drip to the patient. You're supposed to hold it and give potassium correction so that you can bring the potassium back to normal. Because if you give insulin, you see what problem is, insulin will send, I think you all know this, insulin sends potassium into the cells. That is why we give insulin in even dangerous hyperkalemia to bring down the potassium values. It can decrease potassium by 0.5 to 1 milliequivalent over an hour. If a person is having a pre-existing hypokalemia and you give insulin drip, potassium values will decrease even further. And what is the risk with dangerous hypokalemia? If potassium decreases very low, it can cause torsades de pointes. If potassium becomes very low, it can cause respiratory failure in a patient. So learning point here is insulin drip should be withheld if potassium is given to be low in the question. And second, what would you initially give in the patient? Then you don't start with the insulin drip. You first correct the dehydration, get the BP up to, I'm not saying 120, at least get it up to at least 80-90 millimeter of mercury, because of the fact that you need to ensure auto regulation of vital organs in the body. So you give normal saline as a fluid of choice for both of these complications which are given. And lots of time in the exam they ask you simply initial management, that's normal saline followed by insulin drip in both the situations. It is just that the bolus dose of insulin is what is recommended with respect to diabetic ketoacidosis and not with respect to non-ketotic hypersmolar coma. Then I'll be describing before you long-term complications that can be seen with diabetes mellitus. The earliest fundus finding that you will encounter in diabetic retinopathy would be a development of microaneurysms. You very well know there are 10 layers in the retina. So the question said that these microaneurysms would be found in which layer of the retina? Then your answer would be given as the inner nuclear layer. Just to assist you with remembering this, I can mention a mnemonic here by the name of MAIN, M-A-I-N. M-A-I-N, as the name suggests, would stand for microaneurysm, and then would be I-N would stand for inner nuclear layer of the retina. When it comes to type 1 diabetes, it will usually take 5 years for the retinopathy manifestations to occur in a patient. When it comes to type 2 diabetes mellitus, it is 15 to 20 years so that the patient ends up with development of these findings, and then gross subsequent findings would be in the form of a non-proliferative retinopathy and a proliferative retinopathy. If the question says fundus finding or non-proliferative retinopathy, then you know this should be answered as macular edema. But if he says finding a proliferative retinopathy, I think one of the very easy questions here, that would be neovascularization. And due to this neovascularization, I can also have is a retinal detachment, a vitreous hemorrhage, and therefore the person will become blind. Now my objective is to prevent the blindness from occurring. So we'll go in for a pan-retinal photocoagulation using ND-YAG laser. And along with this, we shall also be giving intravitreal injections of anti-VEGF. This would be bevacizumab, Bevacizumab is a anti-vascular endothelial growth factor. This injections would be given intravitreally. Ideally, to prevent blindness, I should have had good sugar control. Had the patient ensured that his HbA1c was less than 7%, this would not have occurred. I mean, everything that I've said on the slide is valid only if HbA1c values are more than 7%. If HbA1c values remain in control, that is less than 7%, cutoff for diabetes is 6.5, right? Cutoff for diabetes HbA1c is 6.5, but if the values are more than 7, it indicates poor sugar control. And therefore, in all of these patients, we should advise for strict glycemic control to prevent these complications from occurring. Diabetic retinopathy usually takes the same time as would be required for development of diabetic nephropathy. So if you are gonna have retinopathy in a diabetic patient identified, that means you should scan out the kidneys as well. Vice versa, if the kidneys are involved, then the eyes should definitely be scanned for. And if he says, what is the most common complication that you see with diabetes mellitus? Long-term complication. The most common complication on a long-term basis with respect to diabetes mellitus would be, that is type 2 diabetes mellitus, obviously would be answered as diabetic neuropathy. Yes guys, don't answer retinopathy or nephropathy. I told you the time frame for both of them is same, 5 years or for type 1 and 15 to 20 for type 2. Duration is an important determinant, but along with that you need a poor sugar control. The combination of two would cause problems. Glucose toxicity is the casual word I can use here. And as I told you, the most common complication of diabetes mellitus on a long-term basis is diabetic neuropathy. For diabetic nephropathy, you can monitor the progression. Now, to monitor the progression, I can definitely check out the KFT of the patient, but the problem is that serum creatinine takes some time to rise. Serum creatinine is not going to rise immediately. It will take some time to rise. So before creatinine rises, I can check out the creatinine clearance of the patient. I can also check out homocysteine levels. Homocysteine not only contributes to premature atherosclerosis, not only does it contribute to development of stroke, but it can also be used to monitor progression. The language of the question was to monitor the progression of a patient who's having a diabetic nephropathy. What tests can be used? Then there are 3 of them. I can definitely use serum creatinine, but creatinine takes some time to rise. So to monitor the progression, I can go in for homocysteine levels. But homocysteine, the problem is that it can be elevated due to vitamin deficiencies, and they could be concomitant atherosclerosis also present in the patient. Therefore, the question says, what is the best screening test for identifying diabetic nephropathy? Diabetic nephropathy is the leading cause of development of chronic kidney disease, and if not treated, if not intervened, then the patient will end up with end-stage renal disease as well. ESRD is said to be present when the glomerular filtration rate of the patient is less than 15 ml per minute, 1.73 meter square of body surface area, to prevent this kind of a manifestation from occurring, where we might require a renal replacement therapy. We might have to go in for dialysis, or we might have to go in for a kidney transplantation. Prevention is always better than cure. So the question said, what can be done for screening of these patients? So for screening of these patients, we will take out the urine sample because kidney is getting involved. And in the urine of this patient, we will be checking in the spot sample urine albumin and creatinine values. Yes, we are not talking about now serum creatinine, but we are talking about urinary creatinine. So I'm talking about albumin, urinary albumin creatinine ratio. I'm writing about UAC, that is urinary albumin creatinine ratio, or I can casually use the word albumin excretion rate. This albumin excretion rate usually is less than 30 milligram per gram of urinary creatinine. It is not 30 milligram per day that I'm speaking. I'm saying normally it is less than 30 milligram per gram of urinary creatinine. If you read any report which is more than 300 milligrams of albumin per gram of urinary creatinine present, it means damage has already occurred. When you say this, a patient might tell you, sir, I got a KFT done. Maybe last Diwali, last Holi festival, there was a health camp in my society. Lal Path Lab organized a discounted camp where they were doing blood test at 50%, and I got my KFT checked and my creatinine was normal. And he's laughing. He's saying, "Sir, my creatinine was normal." He's showing me in his mobile phone, "Sir, I'm sitting before you, talking before you. My creatinine is normal, and you tell me my kidney is damaged." I would tell this guy that creatinine is a very good test. It is the most specific test for kidney damage. Serum creatinine is a specific test for kidney damage, but it rises too late. I want a early diagnosis. So what test would you use for early identification of diabetic nephropathy? Then it is a urinary albumin creatinine ratio. And this urinary albumin creatinine ratio, if it's more than the value that I mentioned, that means damage has already occurred. The guy being a smart chap says, "Okay, boss, I understand what you imply. What should I do now?" You will tell him that we can reduce the progression. We cannot reverse what has happened, but we can reduce the progression towards end stage renal disease. We can reduce the progression towards the various grades of CKD that can occur in a patient by usage of low dose ACE inhibitors. He might even argue with you, "Sir, ACE inhibitor I read it's for control of hypertension. I don't have hypertension. Still you are giving me medicine used in hypertension." I'll tell him, "Sir, this has been shown to reduce the progression and increase survival. Otherwise, the progression to CKD will be occurring over a relatively faster time." Now, what I'm saying next is only for academic purpose. He will say, what is the most common histopathological finding that would be encountered in a chap with diabetic nephropathy? The point is that nobody uses a kidney biopsy to diagnose diabetic nephropathy. I mean, it is an invasive test. It's only for academic reasons that I'm discussing before you. The question said most common histopathological examination finding encountered in diabetic nephropathy. But you can understand, if we are having non-invasive test, no, urinary albumin creatinine ratio, creatinine clearance, then subsequently obviously a serum creatinine available, I will use all of them to my advantage. But the histopathological finding that should be answered is diffuse glomerulosclerosis. You also read about nodular glomerulosclerosis, which is called as Kimmelstein-Wilson change, and you are comfortable about it from your pathology classes. So I've not written about Kimmelstein-Wilson, but I've written regarding what is the most common histopathological finding that would be encountered in the patient. Your answer would be given as diffuse glomerulosclerosis. A counterpart MCQ that I'll just say not right would be with HIV nephropathy. Okay, let's just jot it down as well. HIV-AN, HIV-associated nephropathy. The finding that we see from histopathological perspective is FSGS, that is focal segmental glomerulosclerosis. Whereas in diabetes, I did not use the word focal segmental. I used the term diffuse glomerulosclerosis. This prevention, prevention is any day better than cure. So low dose ACE inhibitors will mitigate the impact on the kidney parenchyma primarily, and the glomerular damage can be minimized. Then he loves to talk nowadays regarding diabetic dermopathy. From the NEET PG perspective or PGME perspective, they have asked regarding findings with respect to diabetic nephropathy, and acanthosis nigricans everybody is aware of, which would be I just show the image also for acanthosis nigricans, very easy to identify. The hyperpigmentation, velvety hyperpigmentation in especially the neck area, or maybe in the dorsum of the neck, in the axilla, or in the groin. Now my point is, the question said, where do you get acanthosis nigricans? Then obviously answer is diabetes mellitus, but that was not in the options. If you do not have diabetes in the options, what you should be looking for is PCOD. In the recently conducted NEET PG exam that was conducted in May 2022, there was no diabetes, no PCOD. Then when would you get acanthosis nigricans? You would be getting it even in patients of metabolic syndrome who would be having a impaired glucose tolerance. The topic of metabolic syndrome has been covered in cardiovascular system. There would be 5 findings, out of which 3 should be present, and one of them is impaired glucose tolerance. Suppose even if these 3 are not given, then acanthosis nigricans can also be seen with internal malignancies like carcinoma stomach or carcinoma pancreas as well. So acanthosis nigricans not only is going to be seen with impaired glucose tolerance, but can be seen with malignancies as well. And in the recent NEET PG exam, the answer was metabolic syndrome because the remaining options were not there. Now, if he says which is the most common diabetic dermopathy, then don't answer acanthosis nigricans. The skin involvement in diabetes, the most common one, is not acanthosis nigricans, and neither is what you are encountering at the lower part of the slide, necrobiosis lipidoica diabeticum. Very fancy name, no? So when you read the word diabeticorum, it looks like, okay, this would be the dermopathy seen. Agreed, it is seen, but the overall what you encounter in the patients would be answered by you as a delayed wound repair. You see, in diabetic patients, you would be having is a concomitant angiopathy. There would be a arteriosclerosis of thin blood vessels or usual blood vessels that are present in the skin. So therefore, since the blood supply is lesser, there is a delayed wound repair, which explains why do you read about non-healing ulcer in diabetic patients, especially on the sole of the foot. Now, we use the word neuropathic ulcer. Agreed that nerves are damaged in diabetic, sensation is hampered, little bit of injury, trivial injury can cause a substantial amount of damage because patient does not perceive pain. But then why is it not healing in spite of you using proper antiseptic dressings on a regular basis? Is because of decreased blood supply. So diabetic patients can have a non-healing ulcer on the sole of the foot, but the reason behind development of the non-healing ulcer on the sole of the foot can be ascribed to two problems, a neuropathy component and an angiopathy component. And because skin is getting involved, so that would also be a dermopathy manifestation. Now, in comparison, what they also did in NEET exam 2022 was there were two questions. One was in acanthosis nigricans for metabolic syndrome. Another one that they asked was a skin manifestation that you encounter with the glucagonoma. Glucagonoma will also have impaired glucose tolerance, but don't answer acanthosis nigricans. And you know that from dermatology, he has described that beautifully. That would be a manifestation called as necrolytic migratory erythema. Now, why I incorporated that is simply because of the terminology. Necrolytic migratory erythema has to be remembered in contrast to necrobiosis lipidoica diabeticarum, which is a lesion on this lesion. Necrobiosis lipidoica diabeticarum is found on the shin, usually in a female patient suffering from type 1 diabetes mellitus, and exhibits a central clearing as well. Now, because I described a lesion on the shin, it also becomes important for me to describe another lesion that can be found on the shin of the patient, that is pyoderma gangrenosum. I'll just show an image for that also. There was a lesion where the patient's shin was shown, and on the shin, that is just on anterior to the tibia, there was an ulcer present with this slightly purplish. You can see a bit of purple color coming in the periphery and a very unhealthy ulcer present. Now, before we look at when would you be getting pyoderma gangrenosum, another lesion on the shin can be pretibial myxedema, another can be a martorell ulcer. So in fact, I have today described before you 4 lesions that would be seen on the anterior aspect of the leg on the shin. It could be necrobiosis lipidoica diabeticarum, that would be obviously diabetes mellitus, no issues with that. Pyoderma gangrenosum, and your answer would be given as inflammatory bowel disease. On a comparative basis, when I say ulcerative colitis versus Crohn's, then your first answer would be Crohn's disease. Pretibial myxedema is what you encounter with Graves, no issues with that. Yes, you get myxedema even in hypothyroidism. But pretibial myxedema, whenever the word is pretibial, that would be Graves disease, right? And if it is martorell ulcer, yes guys, giving you 5 seconds without looking at the printed notes. Can you tell me martorell ulcer? If you've done it from surgery as well? Yes guys. Martorell ulcer is one that would be encountered in patients who are having hypertension and would also be positive for various risk factors for atherosclerosis. Like this guy could be a smoker. Now, usually in smoker, you obviously read about an arterial ulcer with thromboangiitis obliterans, but then the ulcer that is seen in thromboangiitis obliterans would be on the dorsum of the foot, and there would be gangrene of the toes. I repeat once again, in a smoker, hypertensive patient, let me say, if there is gangrene of the toes and there is an ulcer on the dorsum of the foot where the dorsalis pedis artery is supposed to be present, then it is an arterial ulcer. But I described a hypertension patient with atherosclerotic risk factors with lesion on the shin, which would be a painful lesion but relatively less common, that is martorell ulcer. So here I have used this opportunity to talk about some endocrine conditions. The slide is a bit miscellaneous because it not only talks about diabetes mellitus but some other endocrine conditions also, and these are the aspects, especially the ones in blue, which are mentioned on this particular slide. Apart from the most common presentation of diabetic dermopathy, are the ones, there are a total of 4 and 1 5 points which are must know from this particular slide. The next topic we'll study is primary Addison disease, and one of the leading reasons why the adrenal gland can be damaged is autoimmunity. We can be blaming autoimmunity for type 1 diabetes, 1.5 diabetes, Addison currently, and even in hypoparathyroidism, where there would be autoimmune destruction of the parathyroid glands causing a low PTH and resultant hypocalcemia. In India, one of the important causes for why Addison disease can occur is tuberculosis. The clinical features would be primarily of aldosterone deficiency causing salt wasting and then postural hypotension. Postural hypotension can cause dizziness and even recurrent falls in these patients. The definition of postural hypotension would be a fall in systolic blood pressure as well as diastolic when you're doing a tilt table test, or if you don't have a tilt table test, you can request the patient to suddenly stand up from a sitting position or a supine position, taking care that he does not fall, and you should wait for 3 minutes to let the compensatory mechanisms to act. If you find that after 3 minutes of compensatory mechanisms being given sufficient time to act and still there is a fall of systolic blood pressure more than 20 and diastolic blood pressure more than 10 millimeters of mercury, when we call it postural hypotension. The deficiency of cortisol in these patients will explain hypoglycemia, and because there is a cortisol deficiency, so by feedback mechanism the values of ACTH in these patients will begin to rise. Now ACTH has a partial MSH like activity, which will explain the fact that why in these patients would you be getting hyperpigmentation, and this hyperpigmentation is not going to be all over the body but is mainly going to be focused on the palmar and the sole creases, or could be present in the flexular areas like the groin or the axilla, or could be present on the gums of the patient, gingiva, or even on the tongue. Hyperpigmentation is one of the important diagnostic features that we see in primary Addison disease, and why that's important for you to know is because lots of time in multiple choice questions he might actually use the word secondary Addison disease. Now secondary Addison tells you that the problem is not in the gland, adrenal gland, but is in the pituitary. Therefore, if the pituitary will be damaged, ACTH values will become lesser. The best example that you can relate to for secondary Addison disease is Sheehan. Though in Sheehan, multiple hormones will become lesser because the anterior pituitary is busted and destroyed after postpartum hemorrhage, but because ACTH will be less, therefore hyperpigmentation can never be seen in secondary Addison disease. Rather, it will be a pale skin that would be encountered in contrast to hyperpigmentation in primary Addison disease. Now for diagnosis purposes, we need to go in for a screening test and the investigation of choice. The screening test that we'll go in for would be to check out the values of cortisol and ACTH, and you will notice that, as I told you, because the second layer of the adrenal gland is busted by tuberculosis / autoimmunity, therefore there would be less cortisol, and by feedback ACTH would be elevated, and then we would go in for the investigation of choice, which is called as ACTH stimulation test. Now because ACTH stimulation, A for Addison, A for ACTH stimulation test, it's very easy for people to answer and comprehend. Therefore, lots of time in multiple choice questions, you will not encounter ACTH stimulation in the options, mainly because the examiner thinks you can answer it. So therefore, he will rather use these terms like co-centropin test to describe the manifestations in the patient, or describe this would be an alternative term for the ACTH stimulation test that you have to remember. Supporting evidence would be in the form of either an ultrasound abdomen or a CT. And then once the gland damage is demonstrated, you need to give both mineralocorticoid support as well as glucocorticoid support to these patients. So the drug that can be used in this case would be hydrocortisone. Now lots of time you will notice that in the exam he might be mainly interested in asking you regarding management of postural hypotension of these patients, which might be persistent in spite of usage of hydrocortisone. So to make up for this mineralocorticoid deficiency, to make up for this deficiency of aldosterone, you can use a drug which would be behaving like aldosterone, that is fludrocortisone. Similarly, in the exam, he can also try to test your pharmacology by talking about glucocorticoid deficiency, which would manifest in the form of hypoglycemia. To take care of this hypoglycemia component in spite of hydrocortisone supplement being given, then I can be using dexamethasone. The bottom line is that hydrocortisone is sufficient in majority of cases to take care of the mineralocorticoid and the glucocorticoid deficiency, but if required, then we might have to add additional drugs in the patient along with increasing the amount of salt intake. Now, after talking about primary Addison disease, what I'll do is I'll compare Addison with Cons. And in Cons, the issue is that there is a tumor present. Now, because of the tumor, there would be a tumor in the outermost layer of the gland, so there would be more aldosterone, and that explains why there will be more salt and water coming back in the body, because aldosterone is causing more stimulation of epithelial sodium channel, which would be present in the collecting duct. You can also notice in this diagram that there will also be an exaggerated urinary loss of potassium and hydrogen, which will explain hypokalemic alkalosis seen in Cons syndrome. In contrast, as I've already sensitized you to, in Addison disease, the main reason would be autoimmunity, and the hormones that are affected is not only one but three of them. Zona glomerulosa, fasciculata, reticularis, all are impacted either by TB or autoimmunity. So you would have a aldosterone deficiency, cortisol deficiency, and sex steroid deficiency. Aldosterone deficiency would cause salt wasting and postural hypotension. Cortisol deficiency would contribute to hypoglycemia, and then because in these patients there would also be a deficiency of sex steroids, so there would be a loss of pubic hair or axillary hair or regression of secondary sexual characteristics in the patient, plus hyperpigmentation has already been explained. For screening test for patients who are suffering from Cons, we would be going in for a test which is called as ARR, that is aldosterone renin ratio. When I was describing you Addison disease, I said for screening I can check out the values of cortisol and ACTH, but for screening for Cons, your answer is aldosterone renin ratio. And the logic behind this is that in the numerator there is aldosterone. The values of aldosterone will increase exponentially because the tumor will not respect physiology, and by feedback the renin will become relatively lesser. See, what I'm saying is that in the numerator aldosterone values will keep on rising or spiking primarily because there is a tumor present. But at the same time, because of the feedback that would be operating, because aldosterone is more, the negative feedback to RAS system will cause renin values to be lesser. So mathematically, if I take a ratio here, numerator is more, denominator is less, so the ratio will skyrocket. And I also want to sensitize you to the fact that Cons syndrome is an example of low renin hypertension. Traditionally, the causes of hypertension that we read, like renal artery stenosis, chronic glomerulonephritis, polycystic kidney disease, all renal parenchymal or renal vascular diseases are high renin hypertension, but Cons syndrome is an example of a low renin hypertension. If he says what will be the investigational choice, in contrast to what I was explaining to you for Addison disease, where I said co-centropin test or ACTH stimulation test, for the left hand side, that is for Cons, your answer would be given as saline infusion test. And this is anyway important information that should be remembered for the exam. Especially in endocrinology, they love to ask about screening tests and the investigational choice. I'll repeat once again. For Addison disease, I was speaking about a basal test being done, that is ACTH and cortisol values for screening. On the left hand side for Cons, it was ARR, and then IOC is co-centropin test versus saline infusion test. Now we will talk about another condition that is a cause of a low renin hypertension, that is Liddle syndrome. It is autosomal dominant, and the problem in this patient is that the epithelial sodium channel is working overtime. You see, in Liddle syndrome, what happens is the channel is working much more than normal. I'm not blaming the hormone. It is channel which is working overtime. So let's look at what happens if the channel works more than normal, even in the absence of hormone. It will cause an exaggerated gain of salt and water because the arrow has been drawn thicker, so you can understand there would be hypertension, and there will also be a corresponding exaggerated urinary loss of potassium and hydrogen, which explains metabolic alkalosis as well as hypokalemia. This description that I gave you for hypertension and hypokalemic alkalosis was also described for Cons syndrome. So how would you differentiate that whether the case is having Liddle or whether the person is suffering from Cons syndrome can be won with help of a aldosterone renin ratio? You see, in this patient, because there is more salt and more water, the extra salt and water will cause a negative feedback to operate with respect to the RAS system. Once there is a negative feedback with respect to the RAS system, there would be a decrease in the value of aldosterone. Whereas in Cons syndrome, what was I teaching you? More aldosterone. Look at the shocking thing I'm teaching you. Aldosterone is less. Still BP is more. Traditionally, if aldosterone is less, BP should be less. No, like in Addison disease. Here, why aldosterone is less is because of the negative feedback that comes with respect to excessive salt and water in the body. So aldosterone is also less and the renin values are also less, and therefore the ratio can either be normal. The surprising thing is that if numerator is also less, or I would not call it surprising, mathematically I am saying that if numerator is less and denominator is also less, patient is having hypertension. The surprising part is hypertension patients are supposed to have a higher renin value. I'm teaching you cause of low renin hypertension, and I'm also teaching you that the aldosterone renin ratio in these patients would be normal. And if I do imaging in these patients, the imaging either in the form of an ultrasound or even if I perform a CT abdomen, the imaging of this patient of the abdomen will also be turning out to be normal. We'll be able to visualize the normal layers of the adrenal gland. Therefore, Liddle is a differential diagnosis of cons. In cons, it is excess of hormone, whereas in Liddle, it's gonna be excessive working of the channel. Now, for the management of these patients, I would like to use a drug that is gonna inhibit this functioning. And the test that I'm going to use, which will inhibit this functioning overactivity, would be amiloride. So like in Conn syndrome, because there is a high blood pressure in the patient, the drug that will be useful would be spironolactone. Spironolactone is a aldosterone antagonist, so it will take care of the hypertension component. But spironolactone slash eplerenone will not work in a person who's suffering from Liddle, because here the problem is not of the hormone per se. Rather, look at the hormone. The poor thing is saying, sir, I'm not to blame, I'm less than normal. Still there's a hypertension because of the gain of the channel. So I'm gonna inhibit this overactive channel by using amiloride, which would be the drug of choice for Liddle, and Liddle has been asked in previous years in the NEET PG exam. Next up would be Cushing syndrome, where we would be having excess values of cortisol. You see, traditionally what happens in our body is that cortisol values keep on fluctuating. They would be having a nadir, then they'll be having a peak. I mean, cortisol values never remain constant, and they are usually less at about 4 a.m. to 6 a.m. in the morning. And then once we get up in the morning, we are going to our office, because cortisol is the stress hormone. So as we when we face stress in the morning, when we're getting ready for office, school, etc., that is when cortisol values will begin to rise. In a normal individual, the cortisol values will be either having a nadir or a high, but in patients of Cushing syndrome, this kind of a diurnal variation would be lost. The values would always remain elevated. I mean, if you look at the blue curve that I've drawn here before you, what I'm trying to show you is that in a patient of Cushing syndrome, the values of cortisol are definitely more than normal, but there is no diurnal variation. So one of the questions of the previous year said, which of the following is the earliest manifestation that you encounter in patients of Cushing syndrome? And the answer that you would give in that case would be a loss of diurnal variation of cortisol production, as has been shown in this graphic representation. Now, once the cortisol values will increase, you will notice substantial centripetal obesity developing in a patient, moon faces, facial plethora coming up, the weight of the patient. I mean, patient will say, sir, like patient might open his or her social media account, and you may say, look at my picture 1 year ago or 1.5 years ago, and now look at me, and you'll notice that patient will be having a big puffy face, and especially in female patients, you might be even having hirsutism component coming up, because of which you might be thinking in terms of PCOD, but then there would be a lot of other things that would be coming up and not seen in PCOD, like the BP would be spiking. Apart from this, in these patients, because there is more of cortisol, the blood sugar values would be elevated. So these patients would be having an impaired glucose tolerance. Their fasting blood sugar value or 2-hour value can be elevated, and they can even be having secondary diabetes. This is itself a question, no, secondary diabetes, because we read about diabetes mellitus, no, but if one endocrine disorder contributes to high blood sugar, then I can use the word secondary diabetes, and Cushing syndrome is one of the reasons behind it. The number one reason for Cushing syndrome is exogenous. When I say exogenous, that what I imply is that this guy is taking steroids. It may be some kind of non-descriptive medicine, some homeopathic, some Ayurvedic medicine, or some medicine on which there is no label, right? Lots of time there might be medicine sold over the counter which may not be having any label, and that might be having excessive amount of steroids, and any unregulated amount of steroid consumption by an individual can cause Cushing syndrome. But if he says what is the endogenous cause, if he says what is the endogenous cause which would be responsible for it, then the endogenous cause responsible for this can be a pituitary adenoma, and the term that we use for that is Cushing disease. Cushing disease is one of the causes of development of Cushing syndrome in the patient. Apart from this, there could also be an adrenal adenoma. The adenoma will be in the second layer of the gland that can be having an excess production of cortisol, and you will notice that cortisol is increased in all the causes. Whether it's going to be steroids, whether it's going to be oat cell cancer, whether it's going to be adrenal adenoma, in all the causes, you will notice that the values of cortisol will be increasing. But ACTH, that depends on case to case basis. In iatrogenic steroids, in a case of iatrogenic steroids, you will notice that if cortisol is elevated by feedback, ACTH will be less. But with the lung cancer, the ACTH values will definitely be higher. Same is the case with Cushing disease with respect to a pituitary adenoma. And even in adrenal adenoma, ACTH will be less. So two conditions will be having less ACTH, 1 and 3. And two conditions having excess of ACTH would either be a pituitary adenoma or an ectopic source like lung cancer. Now for the screening of this patient, the test that I'll be doing initially will be a 24-hour urinary cortisol. And to increase the diagnostic yield, I can supplement this with the overnight dexamethasone suppression test. You will read about 3 types of dexamethasone suppression tests. One would be overnight dexamethasone, one will be low dose dexamethasone, another one will be high dose dexamethasone suppression test. If he just says the word screening test, your first answer is 24-hour urinary cortisol, and along with this, overnight dexamethasone will increase the diagnostic yield. So a combination of the two will be relatively better, though the single best answer is 24-hour urinary cortisol. Now, if he says in the exam, what is the investigation of choice that should be done for confirming the diagnosis that this is a Cushing syndrome case, then your primary answer is low dose dexamethasone suppression test. And when I say this, the query that would be coming up in your mind would be that, sir, why not a high dose dexamethasone suppression test? So now let me give you justification for the same by showing you a table from Harrison. When you read the term high dose dexamethasone suppression test, it is actually being used for etiological diagnosis. You see, first you diagnose a disease, then you find the cause of it. When I say the word ACTH dependent Cushing, then ACTH dependent basically means that either it's gonna be a pituitary adenoma. And when I say ACTH independent Cushing, it means the fact that ACTH values would be lesser. That means person would be having an adrenal adenoma. Another cause that can also come up for ACTH dependent would be a lung cancer, that is a pituitary adenoma. So one, you can see that if I want to differentiate whether patient is having Cushing disease versus the one a Cushing syndrome caused by adrenal adenoma, I can do a MRI pituitary. MRI pituitary will pick up a pituitary adenoma. I can also do a CRS test, but you can see that high dose dexamethasone suppression test is being done to mainly differentiate between the etiology of the disease. Like I can suppress pituitary adenoma with high dose dexona, but you cannot ever suppress lung cancer, no? I mean, howsoever high amount of dexamethasone do you give to a patient for how many number of days, it really does not matter. You can't suppress a lung cancer. So if I want to differentiate between ACTH dependent and independent, one, I have imaging at my disposal. What I mean by imaging is a CT abdomen for the right hand side that is picking up adrenal adenoma, MRI pituitary on the left hand side. But after all, imaging will only tell you about a tumor. It will not tell you what is the tumor producing. Plus, there is another problem. I also want to differentiate between whether it is a pituitary tumor as a cause, whether it is oat cell cancer as a cause. So to differentiate between these two, I can use high dose dexamethasone for differentiating, because you can't suppress a lung cancer or at all with help of even high dose dexamethasone. Etiological diagnosis, that is where high dose dexamethasone is used. Otherwise, we will be using a low dose dexamethasone suppression test. So I've talked about 3 initially, and I mean, the textbook doesn't say like IOC per se, but he does mention a flow chart, and in the flow chart you will notice in the screening segment he has talked about overnight dexamethasone suppression and a urinary cortisol. Then he's talked about a low dose dexamethasone, and finally for etiology separation he has talked about a high dose dexamethasone suppression, and then based on case to case basis the treatment of the patient would be started. Then is a topic by the name of pheochromocytoma. Well, for pheochromocytoma, lots of time you will encounter this question with respect to what test will be useful for diagnosis, and what I'll teach you in medicine will be different from what is taught in pathology. In lot of previous year MCQs, you will notice that metanephrine, catecholamine, they are not described. So for all older MCQs, especially FMG exam for pheochromocytoma, the test to be done is 24-hour urinary vanillin mandelic acid levels, but that is the answer only with respect to Robbins, because when it comes to a patient who would be diagnosed as per as Harrison guidelines, the answer would be slightly different. So let me now describe before you what Harrison says for pheochromocytoma. If he is talking about screening test, then we can go in for a 24-hour urinary fractionated metanephrine levels. The point is that we want to pick up end products of catecholamine metabolism. Majority of pheochromocytomas are gonna be norepinephrine producing. If he says what is the investigation choice, I'm gonna do a blood test in the patient and I'll do a plasma free metanephrine levels. Even if catecholamine, I mean you can do plasma catecholamine levels also, but then problem with catecholamines is that they have a short duration of I would say surviving in the sample. So by the time you evaluate the sample, it might have degraded into end product. So it's always advisable to go in for metanephrine estimation. And in case these words are not given in the MCQ, that is when vanillin mandelic acid should be answered as far as Robbins is concerned. Majority of these tumors are going to be benign, though some of them 10% can be malignant also. So we read about the rule of 10 also with respect to pheochromocytoma. The 10% can be extraadrenal, they can be picked up by MRI. 10% can be malignant, that again can be picked up with help of a MRI. And then in some cases you would also be having a familial basis, like red proto-oncogene can be associated, and therefore you could be having pheochromocytoma associated with multiple endocrine neoplasia. It could be associated with multiple endocrine neoplasia, especially type 2A, that is called as Sippel syndrome. So rule of 10 comes in with respect to one, I said 10% can be extraadrenal, that is MRI would help, then can be malignant 10%, and then 10% could be having a familial basis with association with multiple endocrine neoplasia type 2A, that is Sippel. Paraganglioma is any extraadrenal pheochromocytoma which could be originating from the sympathetic chain. The mnemonic PHT would always come to your use because there would be palpitations, there would be headache in a patient. The H alphabet here will stand for the headache component that comes in primarily because of hypertension, and D would imply diaphoresis, that would be sympathomimetic stimulation in the patient. Now, once you evaluate these patients, you will notice that the symptoms that are written here, like palpitation, sweating, then even nausea, vomiting, they could be present even in patients of anxiety neurosis. So lots of these patients might actually be on anti-anxiety medication, but there is no improvement. And what you are noticing in this chap is in the subsequent follow-up, there is substantial amount of weight loss, and even his blood glucose levels are turning out to be elevated. Why that happens is because once there is excess of catecholamines, any catecholamine excess will contribute to a spike in blood sugar as well. So fasting blood sugar, 2-hour values in this patient is elevated. And along with this, in the later stages of the disease, a very surprising thing happens. That would be that because the intravascular volume is constricted, the constricted intravascular volume can result in development of orthostatic hypotension. You see, the surprising thing is I'm teaching you there is a hypertension present in this patient, but in the later stages of the same patient, because there is a constricted intravascular volume, there would be a hypotension. So you don't get hyper and hypo. I'm not saying simultaneously. Initial part of the disease, hypertension. Later part of the disease, you have a hypotension because all blood vessels are terribly constricted. So there is no space for the circulating fluid volume. And to assist you in the MCQ, lots of time he would also mention regarding the characteristics of hypertension, because catecholamines have a short duration of action. So he will always mention regarding paroxysmal hypertension or episodic hypertension. And most questions usually end up with talking about either the workup of these patients, or he talks about this rule of 10, which I said verbally, and is also taught in pathology. So I did not write it down. The next thing that I'll explain to you is with respect to the thyroid gland. And with respect to thyroid, I just want to say that because it is covered in surgery as well, therefore I am trying to mainly focus on some selective issues here. One, when they give you a thyroid scan image in the exam, then you know that normally a thyroid scan will be showing up a warm uptake. Warm means normal, but if it is cold nodule, then you have to suspect malignancy. And the usual cancer that the commonest one that we encounter is papillary cancer of thyroid, which is associated with radiation exposure. When it comes to a diffuse increase uptake, then you have to think in terms of Graves' disease. Though ideally in Graves' disease, you don't even need I would say a scan like this. Rather, a diffusely enlarged thyroid gland along with FT3, FT4 increase, TSH becoming undetectable, and checking out for antibody. You will be checking out for thyroid stimulating antibody, or is also referred as LATs, that is long acting thyroid stimulating antibody. It behaves like TSH, stimulates the gland, so T3, T4 will be ultra high and TSH will become undetectable with respect to Graves' disease, which is one of the leading causes of development of hyperthyroidism. But in case it is a toxic nodular goiter, then you will notice that there will be asymmetrical uptake and there would be hot and cold nodules present. On the other hand, in case they give you an image in which there is a diffuse reduction in the uptake, then you have to think in terms of Hashimoto's thyroiditis. And while I'm writing it, you can comment on the antibody responsible for Hashimoto. Yes, guys. Antibody responsible for Hashimoto's thyroiditis. You would be answering that as anti-TPO, that is thyroid peroxidase antibody. In fact, there's a thyroid antibody profile, no, where you check for anti-TPO. Then there's another one here that would be answered by you as anti-microsomal antibody, not anti-mitochondrial antibody. Anti-mitochondrial antibody is what you read with the primary biliary cirrhosis, but anti-microsomal antibody present here. So with respect to, I would say, thyroid gland, because this is covered even in the surgery part, so I am being selective with my information. And one another aspect that they can ask you is that if you are noticing in the thyroid scan that there is going to be a complete suppression of the gland, like all you are noticing is a single black area versus the second one where there's a bit of a black area with remaining gland being visible, then the answer will vary. If you are noticing only one black area with suppression of whole of the remaining gland, then you will call it a autonomous nodule. But if it is going to be like one dark area and then relatively a grayish area present, that is remaining gland is still visible, you will answer hot nodule. So from this particular image, I can say it's only hot and autonomous nodule that can have error of judgments, because the remaining ones are relatively easier. Diffuse increase uptake or diffuse decrease uptake, then would be a cold nodule easily visible, and a combination of hot and cold that would be with toxic multinodular goiter. Another feature that they've asked is one of the reliable signs for identification of hypothyroidism. In fact, I can write for both of them, just like for hyperthyroidism. One of the reliable findings would be increase in the sleeping pulse rate. I mean, you don't read about sleeping pulse rate being increased on a regular basis. One of the reliable clinical signs that you check up for hyperthyroidism in a patient or thyrotoxicosis would be an increase in sleeping pulse rate, primarily because thyroid hormones have a sympathomimetic drive. So he can write either the word sleeping pulse rate is increased, or he can say the word resting tachycardia. On the other hand, if you read a question which is talking about T4 and T3 being lesser, that is hypothyroidism, and he says which of the following is a reliable finding, then don't answer myxedema. Your answer would be given as a hung up. Your answer would be given as a hung up ankle jerk. The reason for that being that there is a myxedema of the Achilles tendon. So as a result of it, the relaxation phase of the DTR will be hampered. If you get a question that just says hung up reflexes, here I told you hung up ankle jerk. If the question simply says hung up reflexes, then I've told you neurology, the answer would be given as chorea. But if it is hung up ankle jerk, it would be hypothyroidism given. Then one of the complications, or rather a life-threatening illness that can be seen with hypothyroidism and can be asked in the exam, is myxedema coma. For these patients, you will have to stabilize the body temperature, and the reason why these patients suffer from coma is mainly because the body temperature, the core temperature begins to fall. Most of the time, this will be a hypothyroid patient who's having an intercurrent illness. Just like I was saying, no, a diabetic patient having an intercurrent illness, they could be like triggering or diabetic ketoacidosis or non-ketotic hypersmolar coma. Similarly, in a hypothyroidism patient, if there is an intercurrent illness, and especially if the patient is also poorly compliant or non-compliant, then the thyroid hormones in the body can be so less that the core temperature in the body will begin to fall. Hypothermia is defined as core temperature less than 35. As it goes down towards 34, 33, 32, then the patient will start feeling drowsy and the consciousness level of the patient can be reduced. So traditionally we read hypothermia occurring at Leh or Ladakh or in soldiers posted at high altitude. But today I taught you that hypothermia can be so bad that it can cause loss of consciousness in a hypothyroidism patient and can trigger myxedema coma, for which you will admit the patient and then give intravenous liothyronine, one of the drugs that would be used in myxedema coma, which is triggered by intercurrent illness. All endocrine emergencies are triggered by intercurrent illness, so liothyronine will be given. And along with this, because in all endocrine emergencies you need to take care of the stress hormone also, so hydrocortisone shot would also be given. I mean, why hydrocortisone here is mainly because this is an endocrine emergency, so to help the patient tide over the crisis, then hydrocortisone shot can also be given in these patients. With respect to the thyroid topic, I would like you or suggest you to focus more on aspects from surgery because they are the ones that are usually asked. And I will lastly talk about MEN syndrome, that is multiple endocrine neoplasia. Earlier we used to read about it as MEN 1, 2A and 2B, and now we tend to read about this as in the current edition of the books as MEN 1, MEN 2 and MEN 3 as well. When it comes to MEN 2A, the alternative term that we will also read about is Sippel syndrome. So let's just work out the manifestations that are usually seen. With respect to MEN 1, you will read about a patient having a pituitary adenoma. This could be a prolactinoma, for example, which can cause galactorrhea. Then would be a parathyroid adenoma. This will contribute to hypercalcemia, and whenever calcium values go in excess of 15, there can even be a systolic arrest in the patient. Then the patient can be having a pancreatic adenoma also. Now we very well know that the commonest pancreatic adenoma is insulinoma, but in multiple endocrine neoplasia, if he says which is the leading pancreatic adenoma, then the answer is Zollinger-Ellison syndrome. I think all of you are aware of the fact that the commonest functioning pancreatic tumor is insulinoma, but whenever he talks about MEN 1 per se, then don't answer insulinoma. Your answer for a functioning pancreatic tumor in MEN 1 is Zollinger-Ellison. That would be a gastrinoma. Now when it comes to MEN 2, what happens is that the pituitary goes out of the picture, and simultaneously even the pancreatic adenoma also goes out of the picture in this particular case, and the parathyroid is able to retain its position. So what's the other P that is coming up here would be one pheochromocytoma. This will cause episodic hypertension in these patients, or maybe he might say paroxysmal hypertension, and the BP will be elevated for maybe few minutes to few hours. And then another entry that comes up here is medullary carcinoma thyroid, which is well known by a tumor marker by the name of calcitonin. You very well know the tumor marker here is calcitonin, which does not mean that the patient will be having hypocalcemia. We don't have a hypocalcemia present here. This MEN 2A, that is Sippel syndrome, is related to abnormal gene that is called as RET, R-E-T, Ret proton cogene, that sits on chromosome number 10. In the current NEET PG, that is my 2022 NEET PG exam, there was a question on MEN 2B, that is also called as MEN 3. And the former American president Abraham Lincoln was said to be suffering from multiple endocrine neoplasia type 2B, and I just thought, towards the end you would be tired listening to me, so I just showed you an article from Nature, and this journal says that what Abraham Lincoln was suffering was multiple endocrine neoplasia. He was a very thin, skinny guy with a Marfanite habitus, and he had bumps on his lips and on his tongue. So I mean, let's look at the manifestations here. 3 M's coming up. One of the M's that you need to remember for multiple endocrine neoplasia would be Marfanoid habitus. So I did not say Marfan syndrome, but I just said that the arm span of the patient can be more than height. Then the second M, which is to be remembered here, is for mucosal neuromas. These mucosal neuromas would be contributing to bumpy lips in these patients. The third M here would be a medullary carcinoma thyroid. So you can see that now the parathyroid adenoma has gone out of the picture. Like when I described the description to you with respect to 3 P's, you could pick up pituitary adenoma straight away going out of the picture in the pancreatic adenoma. And then subsequently you're noticing that it is pheochromocytoma that is retaining its position. and it is the parathyroid adenoma that is getting removed with respect to multiple endocrine neoplasia type 2b. And while describing this information, I would also like to recommend you at this point of time, though I know that you're tired listening to me here, I would also suggest you to listen to the integrated MedPath videos as well. That would give you, I would say, I always say this, that knowledge is power, but I just want to say that that would give you a bit of more orientation, because at this particular point of time, when I'm talking about towards the end in endocrinology, I'm not taken care of some genes and chromosomes which might be asked, especially with respect to men, but I've covered that in the integrated section with respect to MedPath, where you would also be seeing a couple of slides as well, and would this would help you actually score relatively better. So these are the details that I would like you to remember, and yes, keep the pressure on, keep on learning, keep the fire burning, and you will break on to the other side.